Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 570 of our pharmacotherapy series, which majors in attention deficit hyperactivity disorder in children, adolescents and adults. The first case reads: MTM is a 12-year-old girl who recently started middle school. MTM's mother calls the pediatrician looking for advice. MTM was adopted at 2 months of age from Guatemala, and little is known about prenatal care or her life before the adoption. MTM is having a good deal of difficulty with the transition to middle school. She seems overwhelmed with the amount of work and has become withdrawn and angry. The guidance counselor has called the parents because MTM has missed most of her homework assignments. MTM's mother feels at a loss because MTM now has many more teachers and they don't seem to know her or to support her in the same way as the teachers in the elementary school. MTM has begun counseling with a social worker in the community, but does not want to go. Her mother is interested to know if medication may be of help. So my first question to you reads: what do you think about the differential diagnosis? The correct response is, depression is the most prominent diagnosis that comes to mind. However, it is important to remember that comorbidity is quite common in youth with psychiatric disorders. It is important to consider if there are underlying, less obvious disorders or circumstances that may be contributing. The next question reads: what are the next steps in the evaluation? The correct response is, the pediatrician refers MTM to a child or adolescent psychiatrist for evaluation. The professionals help the parents request an educational assessment through the school. The latter includes both an academic and psychologic assessments. The assessments suggest underlying poor self-esteem. However, there is also evidence of slow processing speed and other evidence of attention deficit hyperactivity disorder and executive functioning deficits. The Vanderbilt rating scales confirm the diagnosis of attention deficit hyperactivity disorder. There are a number of validated instruments to assist with the diagnosis and clinical management of attention deficit hyperactivity disorder. Often, these instruments have a parent and teacher version. Commonly used instruments include the Conners Global Index, the SNAP-4, Du-Paul rating scale for attention deficit hyperactivity disorder, and the Vanderbilt rating scale. Some rating scales are proprietary and others, such as the Vanderbilt, is in the public domain. The next question reads: what are the first-line interventions? The psychiatrist provides psychoeducation to MTM and her parents about attention deficit hyperactivity disorder. They discuss that attention deficit hyperactivity disorder may be missed more commonly in girls, and that youth with attention deficit hyperactivity disorder often develop concurrent depression, anxiety, conduct disorders, and substance use disorders because their experience in school and activities often leads to feelings of inadequacy. Additionally, an individualized educational plan, abbreviated as IEP, is developed for MTM to provide more supports in the school setting. Special accommodations such as added time for exams, a seat in the front of the class, and the availability of fidget toys are specified in the individualized educational plan. MTM continues in counseling with the social worker, in which they focus on cognitive and behavioral strategies to manage both her attention deficit hyperactivity disorder symptoms and her depression and poor self-esteem. All agree that it is prudent to hold off on any medication for depression to see if the other interventions are effective in alleviating the symptoms of depression. The attention deficit hyperactivity disorder symptoms are tracked with Vanderbilt rating scales completed by parents and teachers. Medication treatments for attention deficit hyperactivity disorder are discussed. With informed consent, a trial of a psychostimulant is begun. It is agreed upon by the parents and the pediatrician that MTM, the 12-year-old female, will begin using a medication for her attention deficit hyperactivity disorder symptoms. My next question to you reads: what would be the first-line option for MTM? The correct response is either stimulant groups are considered first line, and in this case methylphenidate 10 mg every morning is tried. After steadily increasing the dose to 30 mg every morning, the parents feel that there is minimal change in attention, but that there are significant side effects of nausea and loss of appetite. The next question reads: what would be the next trial of medication for MTM? The correct response is expert guidelines state that if medication is decided upon, then the greatest efficacy is from the stimulants. Neither stimulant is considered superior to the other, and initial choice should be based on the comfort level of the clinician and patient or parent acceptance. If the initial choice of stimulant is ineffective, it is recommended to trial the other stimulant class. By doing this, 90% of children will display efficacy. Therefore, the next trial for MTM should be the initiation of dextroamphetamine 5 mg every morning and titrate as tolerated to a maximum of 40 mg a day. MTM is showing some improvement on 10 mg every morning of immediate-release dextroamphetamine, but it is clearly wearing off about 4 hours after dosing. Dosing of 10 mg twice daily was tried during a school vacation and found to be somewhat effective. Thus, the pediatrician decided to switch to long-acting dextroamphetamine Spansels 20 mg every morning. This clearly has shown to last throughout MTM's school day, but efficacy is not maximized and some residual symptoms of poor attention and hyperactivity exists. My next question to you reads: what is the next step of pharmacotherapy for MTM? The correct response is increasing the dose to 30 mg every morning is possible. Although a switch from a stimulant to atomoxetine could be tried, data have shown that atomoxetine is less effective than stimulants. Experts recommend that combination therapy of a stimulant and an alpha-2 agonist is appropriate, and studies have shown an increase in efficacy from monotherapy to combination therapy. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 571.